So my name is Christine Parsegan. I'm one of the associate professors of GI Medical Oncology at MD Anderson Cancer Center in Houston. I primarily see colorectal cancer patients based on my personal experience of my mother being diagnosed when I was very young. So that told me from a very young age that I would like to pursue this career, and it means uh, it's extra special to me as a result of that. It's a phase 1/2 trial that is looking at patients with a KRAS G12C mutation that have progressed on standard of care chemotherapies for colorectal cancer, that being 5-FU, oxaliplatin, and irinotecan. These patients are to receive adagrasib, cetuximab, which is now thankfully the standard of care in this population. But we are combining this with a PD-1 inhibitor called cemiplimab. In this case, it would be in the second line or greater setting. These patients will have to have been microsatellite stable, and they cannot have had prior therapy with G12C inhibition. Based on the cancer discovery paper that was just published a few months ago, showing the overall response rate of just adagrasib and cetuximab alone being about 34%. Sotorasib and panitumumab had similar responses and overall response rates. However, these patients, first of all, can do better. We can do better. They are known to have more aggressive biologies. So when we saw this data, we were very excited with the cancer discovery paper, in particular with the progression-free survival in that case of 7 months. But we know we can do better. So our thought was, how can we improve and do better than an overall response rate of 34%? Similar to kind of the BRAF world, we have found that in preclinical studies, adagrasib can enhance the potential for tumor cells to kind of present antigens and essentially recondition the tumor environment to kind of improve the susceptibility to immunotherapy. So we thought, well, this might be a good option to then include immunotherapy in this specific population of patients that preclinically at least has shown to be much more responsive in terms of the immune microenvironment. So that was a little bit of the rationale. So the trial is trying to accomplish a benefit in terms of overall response. So trying to do better than that 34%. We are also trying to expand the duration of response and the progression-free survival. We know that immunotherapy, once it works, it can extend duration of response in our patients. It shuts off the off switch to the immune system, and it lets the body do its job for an extended period of time when it works. So the point of this is not only to increase responses, but also increase the duration of that response. The G12C mutated patients are a little bit more rare to find. Their disease has been known to be, less responsive to some of the standard of care drugs. They are known to have progression more quickly than other tumor types. So this is clearly an unmet need for this patient population. And it's exciting because they have a target that we can address, but we can do better than what we're doing right now. So eligible patients include any patients that have had at least 5-FU, oxaliplatin, and irinotecan. They cannot have any exposure previously to KRAS G12C inhibitors. They need to be microsatellite stable. Of course, they have to be a good performance status and willing to travel. It is available both at MD Anderson and at Mass General Hospital in Boston. So if one or the other is more convenient, we're happy to get the patient on the study. There's really just one arm. So the treatment is adagrasib at the standard dose, plus cetuximab, which is an IV drug, plus cemiplimab. So it's a three drug combination. And this, it is frequent visits, it is weekly visits, so patients would have to be willing to come and be our guest every week or so. But it should be, we anticipate that this will be well tolerated. The adagrasib and cetuximab combination is pretty well tolerated. It had a very good safety kind of profile in the previous studies. And we don't suspect that cemiplimab, the anti-PD-1, is really going to affect or worsen the safety profile, as we know very well that PD-1 inhibitors are quite tolerable. The FDA has understood that we have needed a better drug for this population, as well as the NCCN has accepted this. So they have now moved adagrasib and cetuximab, thankfully, to the second line setting. So patients that have had, for example, progression on FOLFOX can get it as a standard of care with their local physicians. However, we are trying to do better. So we are trying to change the standard of care to now include adagrasib and cetuximab, but also a PD-1 inhibitor, again, to improve response rates in this population of patients with more aggressive biology. One thing that this trial requires, of course, is that patients are aware that they have a KRAS G12C mutation. It is very important to communicate with your physician and ensure that this has been tested. It can be tested on circulating tumor DNA. So even if you do not have enough tissue, if you have ctDNA or circulating tumor DNA positive for a G12C mutation, that is sufficient. And you are welcome to be on the study with that. But it just emphasizes that we can use other modalities to check for these different mutations. And although it is rare, that 3% of the population is very effective in that population. So very important to speak with your oncologist to ensure that all of this testing has been done. We are very fortunate to be collaborating with Cancer on this project. They have been instrumental in supporting this and many other studies, but absolutely instrumental in getting this project up and running. We have very frequent conversations with them. They are very involved in ensuring that this trial was activated and enrolling, and not only supporting the clinical trial, but also supporting a lot of the preclinical data for it as well, as we know that is quite important to kind of set up these trials and understand the science behind them. So very grateful to Stand Up to Cancer, and looking forward to a lot more collaborations with them.